Yes. Start.
35-year-old female homemaker has numbness right hand for 1 week, weakness left upper limb 3 days, weakness right foot 1 day.
Yes. Okay. So start from the numbness right hand for 1 week. How will you approach this patient?
It is incidence onset numbness for 1 week duration involving right hand only.
So, what are the
possibilities? One possibility is compressive neuropathy.
Where?
Like
which nerve?
Involving median nerve.
Median nerve. So, what do you call that situation?
Carpal tunnel syndrome.
Carpal tunnel syndrome. So, you think one possibility is carpal tunnel syndrome. So, in carpal tunnel syndrome, what are the important things you will note? Which are the areas where it's numb?
Numbness involving thenar muscle. Over the thenar muscle.
Which are the fingers which will be numb in case of carpal tunnel syndrome?
Lateral 3.5 fingers.
Fingers. What will be the? Is it a continuous process or is it a variable from time to time?
It is constant. Symptoms will be constant and it may worse over the time.
No, will it be having fluctuation daily? Any activities that will increase it?
On activities, it will increase over the compression. When we on compression, it will increase.
Which are the activities which will increase it?
While traveling, when holding the things, using hand.
So,
symptoms.
Such a patient, which are the signs you would like to elicit?
Phalanx sign.
Phalanx sign. Okay. Any other sign? What is Tinel sign?
To look for regeneration of nerve.
Tinel sign is when you tap the nerve, you get tingling along the nerve distribution. And what will happen if you lift up the hand and keep it over your head, or when you put it down, hang it down?
Numbness increases.
When?
Symptoms.
When?
When put it above the head.
That's right. So that is all. And what are the possibilities, etiological factors you will think if it is a carpal tunnel?
In case of 35-year-old female, first you have to think of hypothyroidism.
Okay. Other issues that can be associated with carpal tunnel syndrome. Any other endocrine problems like acromegaly?
Acromegaly can cause diabetes also.
Diabetes association. What about obesity?
Obesity also can cause.
Any other?
Carpal tunnel syndrome.
Can pregnancy produce the same?
Pregnancy, rheumatoid arthritis, amyloidosis.
Amyloidosis. Okay. There are a couple of things. What are the other causes of numbness of the right hand?
If it is acute onset, we have to first think of in a cerebrovascular accident, but it is over 1 week, there is less possibility. And we have to think of cervical spondylosis.
How does cervical spondylosis produces numbness of the hand?
By compressing the nerve root.
Nerve root.
So, with pain.
So, which are the nerve roots and where will be the numbness?
It will be according to dermatomal supply. In case of CA-T1, it will be over. In case of CA, it will be over the medial 1.5, and in case of C7, it will be on the middle finger.
C7 on middle finger is correct. C6 will be
lateral 1.5.
And medial 2 fingers will be
C8.
C8. Okay, so if it is a root, you may get in this distribution. That's fine. Any other cause for numbness? You said medial nerve, then you said cervical roots. Any other possibility? Any other anatomical structure can produce the problem.
Peripheral neuropathy can cause
Is it unilateral?
small fiber, usually bilateral.
Here is only right hand.
Yes, sir.
So
Then-
what else do you think?
Mononeuropathies can cause.
Which mononeuropathy? You said already median. You already said no.
Yes, sir.
What other mononeuropathy?
Ulnar nerve can also.
Ulnar nerve. Ulnar nerve. How will you find out?
There will be sensory and motor findings usually in case of ulnar nerve involvement.
Okay, tell about that.
Claw hand will be there. Motor
Maybe.
findings
Maybe there. Okay.
will be there. And numbness will be over the hypothenar muscle. And one and a half fingers over the medial aspect.
Medial.
Palmar aspect and 2 and half
So,
over.
so right numbness of the right hand. You said a couple of possibilities. You said. Okay. Come to the next complaint of this patient.
Weakness of left upper limb since 3 days.
Okay. What do you make out of that?
Insidious onset weakness.
So patient woke up from the sleep and found left upper limb is weak.
The first possibility is cerebral.
Only the hand is weak. Whole upper limb is not weak. Patient say, I cannot do anything with my left hand. That was history.
In case of acute onset weakness, my first possibility is cerebrovascular accident.
But the patient was able to lift up the shoulder, full power, and elbow was also full power. Only difficulty was regarding the movement of the wrist rather.
Another possibility is progressive static.
Morning the patient woke up to see not able to do anything with the left hand, cannot keep a good grip, cannot wrist drop. So where is wrist drop coming from?
Due to radial nerve.
Radial nerve. What is the root value of radial nerve? C5 to T1.
C5 to T1.
Where does it come from?
From posterior cord.
Of the brachial
Plexus.
Plexus. Okay. So it comes down. So in which case, where will be the numbness in case of radial nerve palsy?
Dorsal aspect.
Where?
2.5 fingers.
So the specific area where you get numbness of radial nerve is along the first dorsal interossei. Okay, the space between the thumb and the first metacarpal. The triangular area is the specific area for the radial nerve. So how do you localize radial nerve palsy? How do you find out? First of all, there is a wrist drop. What maneuver can you do? What maneuver can you do?
Wrist drop.
Wrist drop. How do you demonstrate wrist drop? That's the question. Simple. How do you demonstrate wrist drop? You ask the patient to stretch out the hand in front of you in a pronated position, and patient will not be able to lift up the hand. That's how you elicit the wrist drop. Patient will not be able to extend the wrist and extend the metacarpophalangeal joints. Okay. So how does it produce weakness, by the way?
Due to weakness of long extensors of
Flexors are all right. Adductors are all right. No. So how does it produce weakness? Why the grip is weak?
Extensors are weak.
So why the grip is weak? Simple.
Extensors are weak.
Whenever the wrist cannot be lifted up, you cannot have good grip. So when the wrist is dropped, your flexors cannot act fully. You can look now itself in your hand. If you put in a wrist drop position, you cannot have strong grip. On the other hand, if you lift up the wrist of this patient, support it, then you will have good grip. That's why the patient says that there's a weakness, but it is corrected when you lift up the wrist. Okay, so it comes from the axilla downwards and supplies it. So how do you localize this radial nerve? How do you know? So how do you know it is an axillary lesion? Lesion is in the axilla.
Radial nerve, there will be supply from the arm, axilla itself, arm, along the lesions above the radial groove, below the different muscles are supplied in each area.
So tell me, from the axilla, how do you localize axillary lesion?
There will be involvement of all the muscles supplied by radial nerve.
Name them, please.
Triceps muscle.
Triceps muscle.
All the triceps.
Triceps.
Brachialis.
Supinator. Brachioradialis. Okay, and where will be the sensory loss?
Sensory loss along the lateral two-thirds of dorsum of hand.
Your sensory loss will be along the back of your arm over the triceps muscle, dorsum of your forearm, and as you suggested, dorsum. Okay, so what are the causes of radial nerve palsy at this level? Axillary causes. Cause in the axilla.
Crutches injury.
Crutches.
Trauma.
That's correct. Then the radial nerve comes down through the wind around the humerus, through the groove it comes out. So how do you localize the middle 1/3?
Long head and medial head will be separated about the groove.
The triceps will be preserved. Triceps will be preserved. Rest of the findings will occur. So which are the common things occurring at this site? Radial groove. Which are the spinal groove? Which are the etiologies there?
One is trauma, fracture of the
mid-arm. Okay. Most common is your Saturday night palsy. When you go to sleep, you compress it. That's the commonest localization there. Then it comes down. The radial nerve comes down to forearm. How will you recognize?
Sparing of triceps and supinator muscle and brachioradialis.
Okay. So, will there be sensory loss if the proximal part is affected?
The posterior interosseous nerve, there was no sensory supply.
No sensory supply, so that will be spared. What are the causes of radial nerve palsy if the lesion is in the wrist? Just like tight handcuffs, tight bangles, tight bracelets. Okay, and at this position you don't expect any sensory loss. Okay, what is the third complaint of the patient?
Weakness of
right foot. So what can be the possibility?
Patient complains of not able to walk and slippers falling.
Falling off, okay. But this patient was able to walk. Patient was able to walk. Okay. Slippers falling off. What are the possibilities comes to your mind? How will you analyze it further?
Any distal muscle weakness is there.
Distal muscle weakness is there. Okay, fine.
If there's any dorsiflexus is weak, and slippers are falling with knowledge or without knowledge.
Okay.
Here we consider motor weakness, so chances more for slippers falling with knowledge.
So second complaint, we concluded that possibly patient having radial nerve palsy, and here the patient has got foot drop. How do you proceed further?
My possibilities are mononeuritis multiplex.
No. Only for this complaint, this patient has got foot drop. What will you do? What are the causes of foot drop and what examination will make to find out what is the problem? If it is a lower motor neuron lesion, where do you localize it?
Nerves, common peroneal nerve.
One is common peroneal nerve. Any other site possible?
L5.
L5, very good. It can be L5 lesion. Anything else? Common peroneal nerve arises from where? Arises from where? Common peroneal nerve, where does it come from?
L5 root.
Sciatic nerve. So can sciatic injury produce foot drop?
Yes, sir.
So how do you differentiate these three? L5 root versus sciatic nerve versus common peroneal nerve.
In case of radiculopathy, there will be pain.
Okay.
And in case of sciatic nerve lesion, there will be associated findings of tibial nerve injury also.
If you look at the muscle power, which muscle power you test for specifically for L5 root?
In hallucis longus.
Gluteus, medius and minimus. Okay. What will happen to ankle jerk in case of sciatic nerve?
Will be lost.
What will happen to ankle jerk in L5 lesion?
It will be lost.
The ankle jerk root value is S12. It will not produce any more. So L5 will not produce loss of ankle jerk. Clear?
Okay, sir.
Yes. Okay. And how will you recognize the common peroneal nerve injury? In all the three you get foot drop. You have to differentiate among them. Where will be the sensory loss in case of common peroneal nerve? The lateral side of the leg. And what will happen to the ankle jerk?
In case of common peroneal nerve lesion, ankle jerk will be lost.
It will be preserved. Okay. Common peroneal nerve, ankle jerk is preserved. Sciatic nerve, it is lost. Okay. And L5 lesion, the sensory loss will be along L5, and gluteus maximus and medius will be weak. This is how you differentiate among the three. And you have concluded that possibly this patient has got common peroneal nerve. So one thing you said was if you have radial nerve palsy, then you said about common peroneal nerve. The first complaint, right hand weakness. No, numbness was right hand, and the hand was weak also. When you come to the histopathological illness, 1 week back, difficulty to hold the objects on the right hand. So what are the conditions where you cannot hold object in the right hand? Which are the muscles and nerves required?
Flexors of the hand and lumbrical muscle.
Okay, you want flexors. So which all nerves you want?
median nerve,
Okay, only median nerve,
ulnar nerve,
ulnar nerve. So ulnar nerve supplies which all muscles?
extensor, flexor profunda,
Hypothenar is supplied
temporis,
by what? Hypothenar is supplied by what?
ulnar muscles.
So name the three hypothenar muscles.
Adductor digital minime,
Very good.
adductor pollicis also supplied by, it is thinner.
Flexor
Thinner
digit
muscle.
minimi,
Flexor
abductor digit minimi, and opponent digit minimi are the three muscles forming the hypothenar eminence. That will be wasted in ulnar nerve palsy. Yes. So, how will you distinguish between C8? Where will be sensory loss in ulnar nerve palsy? You said 1.5 fingers, right? And where will be sensory loss in C8 lesion?
C8 lesion, there will be medial side, medial side forearm
Medial fingers. Medial 2 fingers.
and medial side of forearm.
So how will you distinguish between a T1 lesion and an ulnar nerve lesion, or C8 root lesion and ulnar nerve lesion?
In case of
C8 root lesion, there will be sensory loss on the lateral side of the fourth finger, ring finger. That is not supplied by the ulnar nerve. Okay? And how will you distinguish between ulnar nerve and T1 root disease?
radicular pain will be there in case of root disease.
In T1 lesion, the medial side of the forearm will be anesthetic. That area will be spared in case of ulnar nerve palsy because medial side of the forearm is supplied by medial cutaneous nerve. Is it clear?
Yes.
So what are the common causes of ulnar nerve palsy?
Leprosy,
Leprosy, any nerve. In ulnar nerve palsy, which are the sites where you can get problem?
due to trauma, as it is very
Supracondylar fractures around the elbow. That's good answer. Any other? There may be scars of surgery, and there may be deformities of arthritis, or there can be sinual thickening of rheumatoid arthritis. Okay, and there may be ganglion, tumor. Okay, or it may be part of a generalized multiple nerve involvement. Okay, so what will be the actions of ulnar nerve in the hand? What all things it do?
it is applies introshay, palmar and dorsal introshay, abduction and adduction.
What does it do at the level of the metacarpophalangeal joint?
It is applies profunda, flexor profundae, so extension of the interphalangeal joint, flexion of metacarpophalangeal joint.
Yes, a flexion of the metacarpophalangeal joint. That's position you get in case of. Okay, and what is its action on the proximal and distal interphalangeal joints? Ulnar nerve, normal ulnar nerve.
Extension of interphalangeal joint.
Extension of interphalangeal joints. So when the nerve is paralyzed, what position you take? Extension of metacarpophalangeal joints and flexion of the proximal and distal interphalangeal joints. So that's what is called as
Claw hand.
claw hand. That's very good. Claw hand. Yes. So what additional history you want in this patient? What
there is
additional history you want?
associated pain over the
Yes, this patient has got pain over the affected areas. Yes, there is pain. Right. What else you want?
any deformities, any wasting.
There is wasting of the hypothenar eminence. Yes. History. One history. So, what is your probable diagnosis from this history so far?
Considering all the three symptoms, I consider the possibility of mononeuritis multiplex.
So, what is the definition of mononeuritis multiplex? Asymmetrical, asynchronous, sensory and motor involvement of different peripheral nerves, isolated spatially at different times, minimum amount of two peripheral nerves at different locations is called as mononeuritis multiplex. So when you say mononeuritis multiplex, you have a lot of things going through your mind, and that's exactly what you are asking in the history. So what are you going to ask in the history?
Is there any history of fever?
Why you are asking history in the case of mononeuritis multiplex? Fever.
Infectious and inflammatory cause for mononeuritis.
Infections and inflammation. Easily said. What are the infective causes?
One is leprosy.
Leprosy.
HIV.
HIV, yes.
Lyme's disease, not in our.
Okay, Lyme disease. Okay, completion sake, you say Lyme disease. And you said infection, inflammation, you said. What are the inflammation you're talking about?
Sjogren's syndrome, SLE, rheumatoid arthritis.
So what symptoms for each? That's what I'm asking you. Sjogren's syndrome, what symptom?
Any.
What symptoms of Sjogren's syndrome?
Any chronic joint pain, any Raynaud's phenomenon.
Commonly, Sjogren's syndrome manifests as dryness of the mouth, and dry eyes. The patient will not say dry; they will say grittiness of the eyes. Okay. Second thing is SLE. What symptoms you have for SLE?
Any history of rash, joint pain, any
Rash,
hair loss,
hair loss,
any symptoms of renal involvement.
symptoms of digestive or renal involvement, oral ulcers. Okay. Then any other come to your mind? You said sarcoid. Sorry, you said Sjogren and SLE. Yes.
Rheumatoid arthritis.
Rheumatoid arthritis very rarely can produce. Okay. So you ask history of arthritis. Okay. Then
Polyarteritis nodosa.
polyarteritis nodosa is commonly seen in male patients. It can occur in females also, more common in male patients. They have abdominal pain, hypertension, and mononeuritis multiplex. So abdominal pain. Okay, right. Then
Also think about the possibility of sarcoidosis.
no. Finish off your inflammations. Sarcoid infiltration. Okay.
Vasculitis.
What are the vasculitis you will think in this background? Producing mononeuritis multiplex.
Vagus, then polyarteritis.
So, beginner. What history you want to ask in the beginner?
Pulmorenal symptoms.
The beginner will have upper respiratory disease and lower respiratory disease. So they have otitis media, sinusitis, running nose, epistaxis, polyps, hoarseness voice, laryngeal involvement, then cough, expectoration, hemoptysis. Upper respiratory, lower respiratory involvement. What else in beginner?
Any history of hematuria.
Hematuria, okay. Mononeuritis multiplex, purpurias, okay. Any other vasculitis?
Median vessel vasculitis, polyarteritis nodosa, but it's less likely.
No, other types of vasculitis. So we have to screen all of them. That's why I ask him what history you want. Do you want history of okay, church stroke? What history you want?
Also, any history of any nose,
What's happening in the nose?
septal involvement,
Septal.
polyp.
Okay. Any other vasculitis? Any other vasculitis? Many other vasculitis are there, no? Tell other vasculitis. You have cryoglobulinemia. You have in purpura. So what are the infiltrative diseases producing mononeuritis multiplex, and what history you want? What all infiltrations can produce the problem?
One is sarcoidosis.
So what history you get in sarcoid?
There will be involvement of other cranial nerves. Cranial nerve involvement is more in case of sarcoidosis.
Cranial nerve can be affected.
Skin involvement and any pulmonary symptoms.
Skin and respiratory system. Can amyloid present like this mononeuritis multiplex?
Amyloidosis also can.
Have you heard a disease called diabetes?
Yes.
Can it produce mononeuritis multiplex?
Yes, sir.
It can produce, eh? So why didn't you say that among all these conditions, which is more likely possible, by frequency wise, which is more common?
Diabetes.
So why bring it last? It should have come early. So you summarize history evaluation. Specifically, you should have asked about renal complaints, dermatological complaints, purpura, particularly respiratory, cardiovascular, everything you should have covered. Polyuria, polydipsia, polyphagia. So this is your impression. These three nerves are affected. Over to Stephen for a few questions.
Sir, I'll ask later. Currently.
So what is your provisional diagnosis so far, Neetu?
First possibility, mononeuritis multiplex. Another possibility is first episode of multiple sclerosis.
Multiple sclerosis. Multiple sclerosis, does it take a nerve pattern?
No, sir.
So why do you say that? Does it come on consecutive days or a period of what are the
time?
Patients of multiple sclerosis? Which are the system?
Eye involvement.
What type of eye involvement they have?
Patient may present with blur of vision. Optic neuritis will be.
Optic neuritis. So blood division may be one presentation. Yes. Any other presentation?
Also, there will be weakness.
Weakness. Which weakness? Like hemiplegia-like weakness or paraplegia-like weakness? Which type of weakness?
Paraplegia.
Yes. Can they present as diplopia?
Yes, sir.
When?
Due to brainstem involvement, INO.
INO can be there, right? Any other presentation they can have? Are they able to walk?
Difficulty in walking will be there. Numbness.
Because of what? Why they are not able to walk in a straight line?
Cerebellar involvement.
Cerebellar involvement may be there.
And there will be spasticity.
There can be spastic paraplegia. So multiple sclerosis is not a possibility here. So the possibility has to be in relation to the history given related to mononeuritis multiplex. Okay, so that is our provisional diagnosis. Mononeuritis multiplex, you already mentioned, sequential, asymmetrical, asynchronous involvement of multiple nerves, and the possibilities you have mentioned. The commonest comes first. The accordingly, diabetes mellitus is the commonest worldwide. You have leprosy and you have what? Vasculitis. What is this hereditary neuropathy of pressure palsy? We had a boy, engineering student in our ward, who would have seen whenever he sit in a particular position and that particular nerve will get paralyzed. Next few days it is like that, and after some time he recovers. Then he sits in another position, another nerve gets affected, and again he gets paralysis, and then gradually he recovers. There is a 20-year-old young man in our ward with characteristic pressure palsies, multiple nerves getting affected over a period of time. Okay, so multiple nerves getting affected asynchronously one after another. So how does this differ from peripheral neuropathy?
In case of peripheral neuropathy, there will be symmetrical weakness, symmetrical involvement.
It is symmetrical, synchronous, gradual, insidious.
Progressive.
Insidious, not like this. Here, asynchronous, coming and at variable time, variable position, anatomically different sites, no symmetry at all. Past history, what you would like to ask in this patient?
History of diabetes.
Okay.
And history of any infection in the past.
Infections.
Any history of joint pain in the past.
Okay, fine. Yes. Would like to ask history of each patient particularly was asthmatic and had childhood asthma, and whole family members are having this problem. Any other thing you would like to think of now?
Dextrose.
Is your thing struck off. All family members are having asthma. So with this, what usually be a provisional diagnosis. Provisional. You may be wrong.
Vasculitis. Mononeuritis multiplex due to vasculitis, probably dextrose.
Dextrose syndrome. Okay. Mononeuritis. So what is the current name for this dextrose?
Eosinophilic granulomatosis.
So the previous term dextrose is no more used. And what's the new name for Wegener? No, not microscopic. Any granulomatosis is the polyangiitis?
Yes.
The new names you are expected to know. Okay.
Yes.
So, what are the investigations you plan in such a patient? You have a broad diagnosis now, broad. You need to clinch the diagnosis. How will you recognize first of all? First step, confirm it is mononeuritis multiplex. What's the first step? Second step is etiology.
First step. In nerve conduction study.
Nerve conduction study. What are you looking for in the nerve conduction study?
In axonal involvement.
How will you recognize axonal involvement?
Amplitude will be low.
Low. And how will you recognize demyelinating process?
Velocity.
So nerve conduction was done and confirmed it is mononeuritis multiplex. Now our business is to look for the
Cause.
etiology. Yes. What investigations you plan?
Actually, we are suspecting vasculitis, but before that we have to do routine investigation.
There is nothing routine. What do you want in this patient?
In ESR, CRP, total count to look for any infection.
Right.
Renal function test to look for any renal involvement.
Renal involvement. Okay.
And blood sugar value.
Blood glucose fasting and postprandial is done. Normal. Okay.
And routine urine examination to look for any active sediments here.
Urine was normal in this case.
ANA
was negative.
Anga
result is pending. Which Anka you want and which Anka you want to do?
C Anga.
C Anka. C Anka is what? PR3 Anka is called C Anka. It is commonly seen in vaginous granulomatosis. Okay. MPO Anka, otherwise called as P Anka,
AP.
is seen in case of Church-Strauss syndrome. And there is a third type of Anka called atypical Anka. Okay. So you do Anka in this case. We are waiting for the result. Yes. Anything else?
And you have to look for any workup of polyarteritic. Look for any cryoglobulinemia.
Cryoglobulinemia you want to look for.
And hepatitis C and hepatitis B.
Okay, hepatitis B and retrovirus all done. Okay, so we have got some results here. Tell me which are the abnormal results in this case. Take your time.
Anemia, leukocytosis.
Leukocytosis there.
With eosinophil predominant.
Eosinophil, not predominant, very dominant.
Elevated ESR.
Very much elevated. What normal ESR for this patient? This 35-year-old lady.
35.
How much? How do you calculate ESR? She's 35 years old. What's the ESR expected?
8
divided by 2 plus 5. Okay.
Plus.
Then creatinine and HbA1c is normal. Abnormal things you tell.
Anga, P Anga pattern 3+.
P Anka, when you send for Anka, which one you send? Immunofluorescence or ELISA?
Immunofluorescence.
For screening purposes, immunofluorescence is done, and for confirmation, you do the ELISA. On the other hand, ANA you commonly do for the ELISA for screening and confirmation by immunofluorescence. Okay. What other investigation you would like to do in this patient?
Nerve biopsy.
What you are looking for? Nerve biopsy.
Any evidence of granuloma?
Caseating or non-caseating?
Non-caseating granuloma.
Yes. Anything else you want? You said blood has eosinophilia,
Yes.
but you would like to demonstrate their eosinophilic infiltration into the other organs also. So biopsy is focusing at eosinophils in the extravascular tissues. Eosinophil is 85%. What will be your differential diagnosis at this time for eosinophilia? Eosinophilia must have some cause. No.
Yes, sir.
It has some cause.
We have to look for any bone marrow examination should be done to look for any malignancy.
Eosinophil leukemia can occur, yes. But what are the common things you have seen in eosinophil?
Parasitic infection.
So how will you recognize it?
History and examination any filariasis. And we have to look for IgE.
Do you know something called stool examination?
Yes.
Yes, that may be helpful. Now, is there any allergic disorders where you get eosinophilia?
Allergic bronchopulmonary, ABP, allergic bronchopulmonary.
So how will you recognize that? Allergic bronchopulmonary aspergillosis, how will you recognize?
Sputum examination, the IgE.
That is the last part. When do you suspect?
History, chronic cough.
Chronic cough will be there, yes. Any other point?
History of TB, maybe.
No.
Non-resolving cough with it.
Non-resolving cough, you take X-ray, you find changing shadows. You find eosinophilia, and sputum examination has got black spots. Because black plugs are there. Then you do the IgE to confirm it. And this is not a very common thing. Common things. Have you heard tropical pulmonary eosinophilia?
Yes, sir.
Chronic pulmonary eosinophilic pneumonia? Name some infections producing eosinophilia.
Parasitic infections.
Retrovirus is one. Okay. Retrovirus is one. What is eosinophilic gastroenteritis?
Due to persisting chronic diarrhea, on evaluation we can found there is eosinophilic granuloma, a eosinophilic infiltration in the wall, gastrointestinal wall.
So what will be the situation called as hypereosinophilic syndrome? Hypereosinophilic syndrome. What is the hypereosinophilic state? When the absolute eosinophil count exceed 1500, you call it as hypereosinophilia. In this patient, you can see it is quite high, more than that. So based upon the investigation results given in this patient, what is your final diagnosis?
Mononeuritis multiplex due to vasculitis, Chestrock syndrome.
Chestrock syndrome. So name some other condition producing P-ANCA positivity. Is it specific for this condition, or the other situations where it can be positive?
Polyarteritis nodosa.
No. Polyarteritis nodosa has no specific antibody.
Sclerosing cholangitis.
I repeat, polyarteritis nodosa has no antibodies. That's why it is very difficult to recognize. You have to demonstrate aneurysm formation by doing angiography, and you have to demonstrate histopathology by doing nerve biopsy, muscle biopsy. Like that you diagnose. It's a very difficult diagnosis. Yes, there are no antibody mediation in case of polyarteritis nodosa. Be specific. Very specific. Okay. So other conditions producing P-ANCA positivity:
rheumatoid arthritis,
inflammatory bowel disease like ulcerative colitis. You have got cystic fibrosis. So this is not specific situation for us. So once you made a diagnosis, but is there any diagnostic criteria? There has to be some criteria. Commonly, they are having asthma, chronic asthma, or allergic rhinitis. One. And eosinophilia is must. When do you say somebody is having eosinophilia? More than how many percentage?
more than 20%.
More than 5 is called as eosinophilia, and in this particular situation, it has to be more than 10%. Okay. And third feature is Mononeuritis Multiplex. The fourth feature is X-ray showing evidences. But you didn't say anything about X-ray as an investigation of choice in this patient. No? And then of course, you may do X-rays or CT of the paranasal sinuses. They may also show abnormalities. Last, most important, is extravasation of eosinophils. That's very important. Not only inside the blood vessel, extravascular eosinophilic collection is a hallmark of diagnosis. So when you have a patient of this type, what will be your differential diagnosis? Are there any situations where you can have nasal polyps and asthma and eosinophilia? Aspirin-induced bronchial asthma can have eosinophilia, nasal polyps, and bronchial asthma. How to differentiate chronic eosinophilic pneumonia from this entity? There also you may find eosinophils 40%, 50%, and shadows are in the lungs. How to differentiate?
There will be chronic history of
But
cough.
there is no granuloma. There is no granuloma. Important point. And how any other point regarding the allergic bronchopulmonary aspergillosis? Any other? Allergic bronchopulmonary aspergillosis
There will be cavity.
But anything can be there, but extrapulmonary will not be there. In eosinophilia with anxiety, as we are discussing today, thirst drops, not only the lungs, every other structure is affected. Okay, very important differential diagnosis: hypereosinophilic syndrome. The previous criteria was more than 6 months, eosinophils are high, more than 1500. When you find end organ damage like heart, liver, and all affected, you call it as hypereosinophilic syndrome. Now we have got molecular testing specifically for mutation, the diagnosis of hypereosinophilic syndrome. So this value 85% is very high. So you need to keep very good diagnosis. So what are the structures affected in case of thirst drop syndrome? Other systems, I mean, which are systems that's commonly affected?
Respiratory, upper respiratory, lower respiratory, renal.
Upper respiratory, lower respiratory. Lower respiratory, you can have pleural effusion, shadowing, you may have nodules. Rarely you may have pulmonary alveolar hemorrhage. Cardiovascular system, what all things can happen? There can be infiltration in the myocardium. Eosinophil infiltration may be there. Okay. Commonly these people come with asthma and allergic rhinitis. So we concentrate on the respiratory system. Other systems are not spared. And you may find even gastrointestinal system may have infiltration of eosinophils. That's why it mimics the eosinophilic gastroenteritis. And there may be infiltration of eosinophils in the skin, producing multiple nodules also. How do these people die? How do the people die?
Renal involvement.
Renal involvement can be a cause of death, but commonly they die of extrapulmonary things, primarily cardiac involvement. They can have myocardial involvement, they can have congestive heart failure, they can have pericarditis, pericardial effusion, they can have arrhythmias. What are the phases of this illness? Natural history. How many phases are there?
3 phases.
Yeah, what are they? So
Prodromal.
we said prodromal is a long history of asthma, long history of allergic rhinitis. Second aspect is pulmonary involvement, eosinophilia with the shadowing in the lungs, pulmonary involvement. And the last part is vasculitis. So we have got this patient's vasculitis and he has got neuropathy. So what do you expect to be like neuropathy? What are some symptoms of neuropathy in these patients? How does vasculitis present as neuropathy? What is the symptom of these patients?
Sensor and motor involvement will be there.
There will be severe pain, ischemia of the nerve. The ischemic pain is very bad. Ischemic pain produces very severe pain. So they have a lot of pain. They come with pain. Pain is the most important thing for these people. Okay. So what's the treatment option you have got in this patient?
In this vasculitis phase, we have to give corticosteroids.
Corticosteroids, yes. What's the dose you give?
Oral prednisolone, high dose oral prednisolone.
This type of life-threatening situations, commonly they are pulsed. Methylprednisolone is given 1 gram intravenously. Okay, the 3 doses are given, followed by what?
Followed by immunosuppressive therapy.
What do you suggest?
Azathioprine.
We give
Cyclophosphamide.
rapidly acting drug, intravenous cyclophosphamide. In cycles we give, 6 cycles are given. In between the steroids are given, heavy dose of steroids are given orally. So first methylprednisolone 3, then IV cyclophosphamide periodically every month, along with high dose oral steroids, followed by tapering of this drug and adding other drugs. So you pulse it first. Cyclophosphamide is given, high dose steroids, plus steroid sparing agents like azathioprine, MMF. What is MMF?
Mycophenolate.
Mofetil.
Yes.
Okay. What do you like to ask this patient regarding the previous medication?
Aspirin.
So most important thing you already mentioned, you ask about leukotriene related drug, namely What's that drug? For bronchial asthma. Leukotriene-related drug for bronchial asthma.
Montelukast.
Montelukast. So commonly this patient will give history, long-term administration of montelukast said to be one side effect. Okay. What type of vasculitis is this patient having?
Small vessel vasculitis.
Can we name the other small vessel vasculitis?
GP. GP.
GPA means granulomatous polyangiitis. Beginner. Okay. This one.
Cryoglobulin.
Cryoglobulin number 2. Eosinophilic angiitis. No, as in
Text.
any other microscopic polyangiitis is still another one. Okay.
IG vasculitis. HSP.
HSP is another one. Right. So we have discussed today a patient with Church-Strauss syndrome. How long you want to treat this patient?
Lifelong treatment.
Lifelong treatment. A duration of treatment is indefinite, lifelong, and patient may require follow-up regarding other organs, particularly cardiovascular system, and they may continue to have bronchial asthma. It's not a full stop disease. It is very important to pick up because the patient I am following up, this particular patient, is now 17 years, still running okay. She's going for work, she's doing well, not much problem. So very important to analyze each symptom of signs of our patients. Patient with chronic bronchial asthma, chronic allergic rhinitis, some numbness here, some numbness there. Don't discard it. Always look with suspicion, and each and every investigation need to be carefully looked at. Okay.